Mental capacity is a station that, if I was going to put money on, is likely to come up in your exam. Okay, as a part of, I'll give you all of these. Okay, yeah, all these, whatever I've got, all is yours. Okay, mental capacity is a station that is going to come up. Okay, almost certainly in your exam as one of your 12. And actually, if you understand the principles of mental capacity, you'll pass this station with flying colors. Okay, if you understand first of all, how to assess someone's mental capacity. And once you've assessed their mental capacity, are you able to understand what happens next? Who decides their treatment next if they lack capacity? Okay. Now, for mental capacity, there are two tests that must be fulfilled for a patient to be deemed to have capacity. Two tests. Okay. And if you look at the GMC guidance, now I don't expect anyone to read the Good Medical Practice GMC booklet now. You've got 4 weeks to your exam. You don't need to do that. So I'm going to summarize it as easy as I can for you. In the UK, once you reach your 16th birthday, you are presumed to have capacity until proven otherwise. For any decision, okay, until proven otherwise. 16 here. Now, with capacity, you've got to understand that the decision for capacity is time specific. It can change. You may have capacity today, you may not have capacity tomorrow, and vice versa. You may not have capacity today, but you may have it tomorrow. Example, someone has got an infection, okay? They're delirious, they're in hospital, okay? They're being managed for a urinary tract infection. They're confused. Do they have the ability to decide on medical treatment? Well, you do your capacity assessment and you find that they don't. But then you give them antibiotics, they become better. Suddenly their confusion goes. You ask them that same question about treatment, and suddenly they have capacity. So it's very time specific. You can't just say that a patient doesn't have capacity and that's a lifelong thing. No, it's a time specific decision. And also, it's a situation specific decision as well. So it has to be, you have to determine someone's capacity about something. You can't just simply say that the patient doesn't have mental capacity about everything. It doesn't work like that. They have to lack mental capacity about a specific decision. For example, refusal of treatment, okay? Or DNAR, or being discharged from hospital. So when you determine someone's mental capacity, you're determining at that time, at that very time, the thing that you want to get from that patient that they have capacity about. Do they have it or not? Not about everything and anything, about the one decision that you want from them. Okay. So that's the first thing to understand. You're presumed to have capacity until proven otherwise once you reach the age of 16. The capacity is based upon the time at which it is assessed, and also for the decision you're assessing someone's capacity about. It has to be specific. It can't be 3 or 4 or everything. It has to be one specific decision. Okay. Now, there are circumstances under the age of 16 where patients can have capacity regarding treatment under various legal frameworks. Fortunately for our exam, those frameworks are not tested. For example, abortion, pregnancy, sexual relations, sexually transmitted infections, contraception. From the age of 13 to 16, young females, if deemed to have capacity and they fulfill the criteria, is called the Gillick competency criteria. If they fulfill that criteria, Then, as a GP or as an emergency doctor, if someone comes in at the age of 14 requesting emergency contraception, and you're really happy that they've fulfilled those criteria of competency and capacity, you can give them that treatment. Fortunately, that falls outside the scope of our exam, so we're just going to concentrate on adults and capacity above the age of 16. Okay. Now, the test of capacity. Let's take an example, and then I will relate it to your exam. Patients refusing treatment. Okay? They have, let's take a elderly female, okay, in her 60s. She's coming with rectal bleeding. You've taken a history, you've examined her, and you feel that the rectal bleeding could be as a result of colorectal cancer. The patient is point blank refusing that treatment. She doesn't want to have it done. Okay? Please go and assess her capacity to make that decision. That's your task. And actually, that is a case from the exam. Okay? That very case I've just given you. PR bleeding, refusing intervention and investigations. Please determine her capacity. Let's talk about the capacity test. So, the first part of the test is, does the patient have a disorder of their brain or mind? That is the first thing that you have to answer. Okay? Does the patient have a disorder of their brain or their mind? That means confusion comes under that, by the way. Brain, delirium, dementia, anything, a stroke that has affected your cognition, anything that affects the brain. And you know, delirium, there are 100 things that can cause delirium. Okay? From simple infections like a UTI to anemia to hyponatremia, many things. Does the patient have a disorder of their brain or mind? If the answer is no to that question, you can't proceed with the assessment. And you have to assume that the patient has capacity to make that decision, and you have to support them in whatever decision that they're making. Okay, so that's the first thing. Do they have a disorder of brain or mind? Yes or no? If the answer is no, then you can't say the patient doesn't have capacity. You can't go down that road. They have. They're making that decision for themselves. Yeah. The only way you're going to lose that decision is if your brain's gone or your mind has completely gone, for example, from a mental health problem. That's why when we talked from psychiatry, we talked about how patients with mental health deterioration often lack capacity because their mind is gone. Not all patients, but those that are the most unwell. Anyway, stage 1, disorder of brain or mind, yes or no? The answer may be yes or no in your exam. I do know, and we'll come on to the cases in a moment. Let's assume that it's no. The answer is no, they don't. Sorry, I beg your pardon. The answer is yes, they do have a disorder. Delirium, psychosis, dementia, whatever it is. The next is the actual capacity assessment. Okay, and there are 4 steps to this that you have to know that the examiner will quiz you on. Number 1, about that decision that you're asking for, about refusal of treatment. Do they understand the information that is being presented to them? So for example, this patient's coming with rectal bleeding, and I'm explaining to her that given your age, given your symptoms, given your blood tests, we feel, or I feel, that the next step in terms of management should be with a camera test or a colonoscopy. Now, the reason for this camera test is so that we can now have a look inside the bowel closely to figure out what might be causing the bleeding. Okay? So do they understand that information? The next is, can they weigh up the pros and the cons of the information? What does that mean? That means that I'm going to tell you from this decision, from you having a colonoscopy, the benefits of this are detection of the abnormality. We're going to find out the reason why you're bleeding. If we find out the reason why you're bleeding, we can give you more timely, quicker management. If it's something more sinister, we may have picked it up at an earlier stage where things can be done. For example, cancer. Okay. So what are the pros of what you're deciding on? And then what are the cons? So what are the risks? Okay. Now, I've mentioned to you the benefits. However, with a colonoscopy, there are risks. Okay? The risk of not finding the reason for your bleeding. So you may have this instrument inserted through the back passage, and we might not actually find the source of bleeding. Or the risks actually associated with the colonoscopy, for example, it may cause more bleeding. It may cause a perforation or a small hole to cause in the bowel that on occasions may need repairing. It may obviously cause pain and discomfort. So now she knows why she's having it, or what, so I beg your pardon, what she's having done. She now knows the benefits of doing this treatment or this investigation. She now knows the risks associated with it. And also in weigh up pros and cons, we can talk about alternatives. You may choose not to do the colonoscopy, in which case the alternatives to colonoscopy include things like imaging of the bowel, for example, a CT scan. The problem with alternatives for rectal bleeding is that if we find something on that CT scan, invariably we will need to fall back to the colonoscopy to take a sample of that tissue, which we can't do from a scan. So I've given her the information regarding colonoscopy. I've given her the principal benefits and risks. I've also presented to her alternatives to that procedure. Now what I want her to do, or him to do, is retain that information inside them and tell me back what they've understood. So Mr. Jones, could you just give me a brief snapshot of what you've understood about what I've just discussed with you, and allow them in their own words to explain about the procedure, about the benefits, about the risks, okay, and about the alternatives to it as well. That's the third criteria. Understand, weigh up, retain, and finally communicate. So now that you've understood, you've had a chance to weigh up the pros and cons, and you've told me what you've understood. What is your decision? Now that decision is the patient's decision, okay? That's what she may say, no, I don't want it. Providing that the patient has understood, weighed up, retained, and communicated back to you the reasons as to why she doesn't want it done, she has capacity to make that decision. She may say to you, doctor, I'm 90 years old. If you find bowel cancer, what are you going to do? Okay, I don't want any more investigations done. I want to go in peace, which is fair enough. And that's a lot of patients, when they become elderly and frail, they often refuse investigations. Of course, it's important to determine whether they have capacity to make that decision. And if they do so, then by all means, you document that decision, and the patient doesn't need to have any further investigations. And if they deteriorate as a result of cancer or whatever it may be, then they have already stated to you that my wishes are not to sustain life anymore, but to prioritize my comfort and dignity when I pass. Okay, so a decision doesn't always have to be a decision that you feel is right from a medical standpoint. The patient has to feel right for themselves, providing that all criteria are met. Okay. Now, moving a little bit further about how a patient would lack capacity. If any one of these criteria, okay, any one of these criteria are not met, if they don't understand, if they can't weigh up, if they can't retain or they can't communicate, only one are missing, they don't have capacity at that time for that specific decision. So that's the final thing I want to mention in terms of the capacity test. If one item is missing from your discussion with the patient regarding capacity, they don't have capacity. Now, there are a few questions. Because it's a complicated topic, I'll have a look at the questions now. For mental capacity section of the exam, at the beginning, we talk at the patient and then ask what they were able to retain in an open-ended question to fully assess all the sections, and they were yes. So what you're doing is, first of all, summarizing the reason why you're there, which is because the patient has refused to have an investigation done, and you've come to talk about it. You're not there to tell them, I'm here to assess your capacity. I'm here to talk to you about the actual procedure. Okay? Then you give them the information, the pros and cons. Okay? And then once you've done that, give them a chance to retain it, assimilate that information, and communicate their decision back to you. And if you feel that they have capacity, then so be it. Then they have it. Can we assess mental capacity as F1s? Absolutely. Nurses can assess capacity. Therapists can assess capacity. Healthcare assistants can assess capacity. Any single healthcare professional can assess capacity. How do we judge when a patient with mental capacity loses? Well, if they can't do one of the above, okay? So if they can't do one of the above, then they have lost capacity to make that particular decision. In the exam, do we have to give them a chance to assimilate the information? Well, it's only a few seconds, yeah. So once they've heard it, okay, take a few seconds, let them process it, and now could you tell me what you've understood back? Remember, they're actors, okay, so they don't need time. They already know what to say to you. So you can just simply ask them, what have you understood about what's been discussed so far? So we start by asking if they have any specific conditions like delirium. No, you don't need to do that in this, okay? You don't need to do that. In real life, you need to, for you to complete a capacity assessment, you yourself have to answer that question. Do they have delirium or an effect on their brain or not? That would already be given in the task for you. Okay. Could you go over the impact of whether the patient has a disordered brain? So yeah, so there's two parts of the test. Part number one, does the patient have a disorder of mind or brain? If the answer is yes, then you move on to step two, which is this: understand, weigh up, retain, and communicate. If they don't, then you don't need to proceed any further. Okay? And whatever decision they make, that's up to them. Mustafa, your hands up. Yes, my friend.
Yeah, sorry, my question was from the perspective of me as a foundation year one student entering the whole way and then seeing the patient, and I can realize that he has a brain or mind disorder. What I need to do in this specific setting is to explain for them the reason for the specific investigation or treatment. I need to also tell them the benefits, the cons, and the alternatives, and then ask the patient themselves to briefly summarize them and then listen to what their decision is. Basically, that's all I need to do.
Correct. Yeah.
I
Just
understand.
because someone has a disorder of brain or mind doesn't mean they don't have capacity. It does not mean that. Okay. You can have delirium and still understand certain things. Okay. That's why I said it's a time and decision specific decision aid. Okay. So if someone has a disorder of brain or mind, doesn't mean that they don't have capacity. They can still, dementia patients, you've got varying degrees of dementia. You know, you've got mild, moderate, and very advanced dementia as well. Patients with mild dementia, yeah, they have a disorder of the brain. Doesn't mean that they lack capacity in every decision. They can still make them. Okay, so that's that's capacity for you. Hopefully that's cleared up things. If not, you can always watch the video back again, slowly pause, rewind, and listen again. Okay? Now, let's go down the path of someone lacking capacity. Who do we go to next? Who makes the decision for that patient? Well, patients with dementia or cognitive impairment who have just been newly diagnosed, some of them still have the ability to make decisions for themselves. As I've mentioned, you may have very mild dementia. So what that patient may do is they may write in advance a direction for doctors involved in their care, decisions about things that they want to have done to them. And that's called an advance directive. Okay, so advance directives don't necessarily have to just be written by dementia patients. Anyone can write an advance directive, anyone. Okay, you can go to your GP and say, this is what these are the type of things that I would refuse if I was not able to decide for myself about decisions regarding treatment. So I'm telling you in advance, if I was to lose the ability to decide for myself, this is what I want done. This is what I don't want done. Okay? So that's important. An advance directive, also known as a living will. Okay? Similar to a living will. Okay? So if the patient can't decide for themselves, the advance directive is the next legal document that you will go to in terms of deciding care for a patient, because that's the patient's own words on paper now that was done before. Okay. I thought, yes, they are. Yeah, for refusal of treatments. Yeah, not treatments for the want, just purely refusal of things that they don't want done in the future. For example, about resuscitation, which we'll talk about in a moment. Obviously, a patient can't decide on what treatment they want done when they lack capacity, because that will be a medical decision in that case. Okay. Yes. So advance directive is things that they don't want done in case they lost capacity. Now, not everyone has an advance directive. Not all patients think about this. Not all patients know about this. But the examiner will certainly ask you, once a patient loses capacity, who makes the decision? What legal frameworks are available to make decisions on behalf of patients? And an advance directive is one such document. Now, the next is a lasting power of attorney. A lasting power of attorney can come in two different forms, and it can be, again, any person appointed by the patient whilst they were compos mentis, which means that they had all their mental faculties around them. Once they have cognitive impairment, they cannot legally sign that form any longer. Okay? So in advance, they give the power of attorney over to someone who can make decisions on their behalf. And it can be a relative, it can be a friend, it could be a neighbor, it could be anyone appointed by that patient. And you can have one for health, you can have one for wealth, or it can be the same person for both. So lasting power of attorney is another legal, this is a person who can make decisions on behalf of the patient. And finally, the medical team. Okay? Usually the consultant who is in charge of the patient's care. Okay? Consultant or the medical team who are looking after the patient. So once you do your station for capacity, the examiner's questions at the end are very straightforward. Does the patient have capacity? Yes or no? It's either yes or no. And if it's no, why? What parts of the assessment did they not fulfill for you? Okay. If a patient has an advance directive and a lasting power of attorney, which one is followed? I don't think they're going to have both. I believe an advance directive from the patient supersedes a lasting power of attorney, but I don't think you're going to get as complicated as that. Okay. So, questions from the examiner. regarding capacity. Okay. Yes or no? And if no, why not? And in the case of no, what other legal frameworks are available to make decisions on behalf of the patient? Advance directive, lasting power of attorney, and finally, the medical team. Okay. Now, there's an interesting question. Let's say, and we'll talk about this in a little bit more detail when I do DNAR for you. Let's say that patient has capacity. They have capacity. But they're requesting for a treatment that you feel is not in their best interests, or actually is dangerous for them. For example, I'll give you a small example. Okay? Patient wants contraception. Okay? 20-year-old female wants contraception. She's currently being treated for a DVT. She has a background of hypertension, liver disease, and migraines with aura. So she's got every single contraindication to using the COCP, but it's her decision. She wants the oral contraceptive pill as part of her contraception regime. Are you, as the prescriber, obliged to give treatment that you feel is not in the patient's best interests? The answer is absolutely no. You are the prescriber, okay? If you feel that the patient who has capacity is demanding treatment that is dangerous or harmful for you, then the answer is no. Okay? And I'll ask the question about a different decision. What if a 90-year-old female with metastatic malignancy, who's compos mentis, okay, asks you, or you talk to her about resuscitation, and she says to you, I want to be resuscitated, doctor. I want you to try everything for me, okay? I don't want to die without you trying everything for me. What are you going to do then? Again, she has that decision. Again, it's a medical decision, okay? So although patients can have capacity to refuse intervention and treatment, they can't demand treatment from you, okay? Demanding of treatment, you can always have shared decision making with patients, but they can't demand treatments that will cause harm to one, okay? And DNA CPR is no different to the case of giving a COCP to someone with DVTs, okay? A resuscitation in someone who's got metastatic malignancy, in which the percentage of chances are almost zero, if not zero, the answer is no. Okay. Similarly, with a lasting power of attorney. Okay. Can you please repeat the COCP? Yeah. So I mean, that was just a small example of the COCP. If someone, for example, if someone's asking for a tablet that is contraindicated to them, can you give it? The answer is no. Okay. And the example I gave was the oral contraceptive in someone with a deep venous thrombosis. Because it's contraindicated, I'm not going to prescribe it for you, even if you have the capacity to make that decision for yourself. Okay. Anyway, next of kin, this final issue of next of kin. So, sort of the next in line for the patient could be a wife, could be husband, could be a mom, could be a dad, it could be a child, okay, or a son or a daughter. Next of kin is someone who you involve in the treatment making the decision making process. However, they don't have any legal standing to influence your decision making. So out of respect, of course, if you're going to make a DNAR decision for someone who doesn't have capacity, you will always involve the next of kin, because it's a matter of ethics and respect. I'm not going to sign a DNAR form without telling the daughter or son who's the next of kin, that I've done that. Because if mom dies and daughter asks, did you try and resuscitate? And I said, no, because she had a DNA. But did you discuss that with me? That's an ethical problem. Okay. So it's not really a legal issue with the next of kin. It's more of one of, it's more of an ethical issue. So the next of kin is involved in the patient's care. However, they don't have any legal bearing on decisions that are made for that patient. Whereas an advance directive does, lasting power of attorney does, and of course the medical team has the overall responsibility of that patient. Dee's asked if the patient has capacity, if the patient has capacity but is refusing life-changing treatment, what do we do? Then that's up to them. You can't force treatment upon someone. Okay, it's that kind of situation. And then I'm only talking about adults at the moment, not children. Children's different. It's I think of the example of the Jehovah's Witness who refuses a blood transfusion in the case of, let's say, he's had a major trauma. Okay, but usually they'll have an advance directive to state that even in an emergency, okay, I would rather go than you give me blood. Okay? So yes, they can. No, I don't think there's a legal. It's not. So spouse is a lasting power of attorney if they sign a legal document. Yes. Yeah. So a lasting power of attorney is a legal document that has to be signed in front of an advocate by the patient to say that this is now the person that makes the decisions on my behalf. Okay. So that's capacity for you. Everyone's presumed to have capacity up until the age of 16. Okay. If you feel that a decision on capacity is necessary because you feel the patient's confused, delirious, has dementia, has an acute mental health illness, then you have to do the capacity test, which is the 4-point test of understanding information, weighing up the information, retaining the information, and then communicating their decision. If those 4 are ticked, they have capacity. The sort of decision is theirs. If they lack on one of those, then they don't have the capacity, and then it falls to one of these. Okay, the advance directive, lasting power of attorney, or the medical team. Okay. Does LPA have power for a patient with good mental capacity? No. Patient always has power. Okay, patient first. What if it's an adult with learning disability? Do you assess the capacity in the same way? Exactly the same way. Exactly the same way. However, when it comes to capacity assessment, you have to do everything in your power to be able to give that patient the ability to show they have capacity. For example, if someone's got a profound deafness, profound hearing impairment, okay, and you want to assess their capacity, you have to do everything in your ability to be able to help them to make that decision. For example, bringing in an interpreter who speaks sign language. Okay, until they, someone who speaks sign language, making sure their hearing aids are working. For patients with learning disability, using a different type of language for them. Okay, maybe asking someone who's closer to them, who speaks with them, who understands their speech, for example, or etc., who can put that information across to that patient. So learning disability, patients who can't speak for themselves, patients who can't hear for themselves, okay, they have to be given every chance of getting their capacity assessed with whatever tools that you have available. Fortunately for your exam, these issues won't be you're not going to have someone with mental learning disabilities or speech impairment or hearing impairment for capacity assessment. It will be someone who is able to talk and listen back to you. So that won't be the case. Okay. Okay, so let me move on now, okay, to the actual scenarios that can come up. Okay. The scenarios for the exam are as follows. You have the lady that I've just mentioned. So the female refusing to have her colonoscopy or flexible sigmoidoscopy performed because of whatever reason. And actually, the reason in the exam, when you actually talk to her, she tells you that she has fear of the colonoscopy. So there's a legitimate reason as to why she's refusing. She's heard things about the colonoscopy, for example, bowel perforation. Her friend had a colonoscopy a few months ago. She said it caused considerable pain. So she's got legitimate reasons to refuse. Okay. However, with that still being said, you still need to explain it to her, give her the pros and cons, give her the alternatives then in that case, and then allow her to retain that information and communicate a decision back to you. Now, once you've alleviated a patient's concerns, you tell her, we're going to give you pain relief. We can even give you medications through a vein to help you sort of be quite relaxed and a little bit sleepy during it as well. Yeah. You know, you can reassure her that the risk of bowel perforation is extremely low. It's about 1 in 1,000. Okay. And even if you do have a cut in your bowel, the cut is so small that it might not, it won't even affect you and it will close over by itself. So you can reassure this patient regarding her reasons of refusal. So this lady actually does have capacity, okay, in the exam. And she's refusing on the basis of misinformation. So then at the end, the examiner will ask, okay, so you've determined that the patient has capacity. What legal frameworks are in place for patients who don't have capacity? And we've talked about them. Advanced directive, lasting power of attorney, and then finally the medical team. Okay. Right. Let me just have a look if there. Do we have the document? I can say. I mean, the mental capacity assessment. This document I will send you anyway. Okay. Or everything I'm going to send you. So don't worry about that. For big decisions, yes, definitely. But for small day-to-day things, for taking blood on the ward, then no. But isn't bowel perforation an actual complication that the patient should be aware? Of course it is. We mentioned that. Okay. But, you know, it's up to her if she wants to take that risk. No, you don't. Sorry. You don't have the document for the exam. No, this is just a discussion that you have with the patient. Yes, I would say they are hierarchical. Okay. Advanced directive is the patient's own words that are written in advance. Okay. Then the lasting power of attorney, and then the medical team has the final decision. Yes, Sari, you can. Oh gosh, I need to unmute you, don't I? Yes, go ahead.
Can you hear me?
Yes, I can now. Yep.
Oh yeah. So for this scenario, do we have to like convince the patient here?
No, no, it's not convinced. No. You're
It's
not
like
getting
a counseling or something. What?
no, you're not getting consent. Okay. You're not getting consent. All you're doing is you're just explaining in short what a colonoscopy is. Okay. Giving them that information, the pros and cons of it, and allowing them to make a decision for themselves if they want to go ahead. This is not counseling for colonoscopy. Okay. This is an assessment of someone's capacity. Okay. So so we're not going through the whole, you know, colonoscopy counseling with them. No, it's simply explaining the reason as to why you're doing the colonoscopy or you're offering the colonoscopy. Okay. What are the principal benefits of doing it and what are the risks? And letting them decide if they want to have that investigation done or not. Okay. So it's not colonoscopy counseling. It is mental capacity assessment And it just so happens in this case, you're talking about colonoscopy. Okay, I'm gonna move on and discuss the other cases a moment. Okay, otherwise we're never gonna finish. Yeah. Now, that's one case. The second case that can come up in the exam is, again, similar to the one that I've just talked about in terms of refusal of treatment, but it's a patient refusing anticoagulation. So we have an elderly lady who's been diagnosed with atrial fibrillation, and her CHADS-VASc score, which is a scoring criteria for stroke risk, has come up to be quite high. So the decision has been made to offer her anticoagulation as cerebrovascular disease prophylaxis. The patient is refusing anticoagulation. Please go and assess the patient's capacity for refusal. So this is the same as the previous one. You're going to, first of all, ask the patient what her concerns are. What is it about so the discussion has already been happened. A doctor has explained to her, you've got AF. This is what AF is. The complications of AF are strokes. Okay. Now we need to offer you anticoagulation to prevent that risk from occurring. So your task is now to determine, one, why is the patient refusing? Maybe now she's gone away, she's taken time, and she just doesn't want it. Okay. And number two, does she have the capacity to make that decision regarding refusal? I'm not here to sell her apixaban or warfarin or rivaroxaban. I'm here to talk to her about her concerns, and her concerns are she doesn't want blood thinners. And in that process of discussing anticoagulation, I am determining whether she has the capacity to make that refusal decision for herself. So I will explain to her again, do you understand the condition that you're currently suffering from? Okay. And then if she says no, I'll explain that you've got a condition of your heart where the electrical activity in your heart is out of sync. Okay. So your heartbeat is not beating as well as it should. It's irregular, a condition we call atrial fibrillation. Now, what happens here in AF is that because the heart is not beating synchronously, often blood can pool in parts of the heart and form small blood clots. And if those blood clots dislodge, they can flick and go inside the brain and cause a stroke to happen. Okay. So in order to minimize this risk of the formation of blood clots, we can offer anticoagulants or blood thinning medications so as to try and minimize this risk from occurring. So the principal benefit of offering you this treatment is that it will not prevent it fully, but it will minimize the risk of you having a stroke. The issue then comes is if we give you blood thinners, that your blood can become too thin and you risk bleeding. So the major downfall of giving anticoagulants is that of bleeding, and often you can bleed from anywhere. You know, some bleeds may be minor, other bleeds may be more significant. For example, bleeds inside the brain. Now and as I said, for the first one, there are alternatives. So there are different types of blood thinning medications we can use. So we have warfarin, and we have some of the newer drugs. Okay. Warfarin has been around a long time. It is a safe medication. We have medications to reverse the bleeding with warfarin. Okay. But the downfall of warfarin is that you require regular blood tests. The newer medications to help thin out your blood, for example, apixaban that can be used, are, again, quite safe drugs, but because they haven't been around for so long, we don't know the long-term safety profile. The benefit of using them is you don't need blood tests to monitor for the effect of these. Once you give the treatment, you assume that they work pretty much straight away. So what I've done here is I've explained to the patient the situation at hand. Okay. First of all, I've acknowledged her refusal. I've acknowledged why she's refused. Now I'm going to go back in my own words and explain to her what I feel has happened so far. Okay? That she needs anticoagulation for this reason. Benefits, stroke prevention. Risks, bleeding. Alternatives, warfarin and NOACs. Now, Mrs. Jones, what I'd like you to do, just so that we're on the same page and so that I'm happy that you've understood the information, could you repeat what you've understood back to me? And she may say, yes, doctor, I've understood that I've got this condition with my heart. It's an irregular heartbeat. And if I don't have blood thinners, then, we can, there's a risk of me having a blood clot. I still don't want them done. I still don't want them. That's fine. She's understood. She's weighed up. She's retained. And she's made her decision. She can change. And how I finish that station is, okay, and I'm happy you've made a decision for yourself. What I'll do is I'll give you a leaflet regarding anticoagulation, okay, these blood thinning medications. You can have a more in-depth reading about them. And if you change your decision, please come back and make an appointment, or I'm happy to come back and discuss this again with you at another time. Okay, that's how you should end this station. If a patient is refusing treatment, but you know that from medically they should have it, but they still don't want it, give them time. Let them read about it. Let them come back and have any more questions that they may have. And then turn to the examiner, who will then ask you questions. Should we use ICE in mental capacity assessment? No. Do we involve senior in this scenario? No. Okay. You don't need a senior to make a mental capacity assessment. You can do it by yourself. If you are concerned regarding whether a patient has mental capacity because you just feel there's something not quite right, but you can't put a finger on it, and you just feel you need a second person, every mental capacity assessment needs two. Ideally should have two people. You can sign it by yourself. Ideally should have two people. So you can always ask for a senior input, but it's not mandatory when doing an MCA. Okay. So hopefully that clears up a little. At what stage of the assessment do we ask about her concerns? Right at the beginning, when you start the station, why is it that she's concerned about this treatment? What is it that's making her refuse this treatment? The station is the patient is refusing anticoagulation. The patient is refusing intervention. So obviously you're going to start by saying, why? Okay. Now I'm going to move forward to DNAR now. Please watch this video back again. Okay. Listen to this again. I've tried to do it as clearly and as slowly as I can. Okay. So hopefully the second time you watch it, everything will be crystal clear when it comes to capacity. I haven't left any stone unturned there for you. Okay. Right. I'm going to move a little bit forward to DNAR, which is the final type of ethical and legal issue station for your exam. DNAR, again, lots of writing. I'm not going to read it. I'm going to explain it to you. As an FY1, you won't be signing DNAR forms. You will not be doing it. Okay. This is normally at the decision of a registrar or a consultant. Normally the consultant who is in charge of the patient's care, they are the ones who sign DNAR forms. I've talked about capacity. If you're at the stage of DNA CPR, do not attempt cardiopulmonary resuscitation. The patient is already quite unwell. Okay. They're already at that critical stage because you're having to think about that decision. DNA CPR decision itself is primarily the patient's decision. Okay, initially, if they have capacity. Okay, think about it. Let's say you've got a long-term, progressive, debilitating neurological condition, for example, Huntington's. You know, by the age of 45, 50, you're going to die. Or let's say you've got metastatic cancer, brain mets, spinal mets, bony mets, and you know your prognosis is 6 months. Do you really think that the person who is suffering from that tragic illness is going to want you to jump up and down on their chest if their heart and lungs were to stop? Most people, the answer will be no. So patients can go to their GP, can go to their hospital consultant, whoever's in charge of their care, and say, doctor, I understand that my illness is irreversible, it's progressive, it's incurable. And I am now at the stage where I'm essentially entering end of life. I want to sign a DNAR form, because if it came to that decision where my heart and lungs were to stop, I don't want anyone to artificially to try and restart that, my heart and lungs again. And that's a very valid reason. Okay. And to be honest with you, a patient doesn't have to give a reason. I've had patients come to my GP surgery. They're not young, in their 50s or 60s, and they talk about DNAR with me, and they don't have a reason. They're fit and well. The guy's playing golf on a Saturday. He's fine. He's driving. He's working. Everything's well with him. It's his choice. Okay. Everyone has a choice how they want to spend, how they want to die. And if someone wants to die without artificial resuscitation, that's their choice. So anyone can ask for a DNAR, providing that they have the capacity to make that decision. Usually it's someone with a critical illness who knows that they haven't got long left, who will sign a DNAR form. Okay. Now in hospital and in your exam, you're more likely to, if you do get DNA CPR as a station, it's more likely going to be discussed either with the patient or with a relative, in the case that the patient doesn't have capacity. Okay, and that will already be specified in your task, that you're dealing with a patient who has capacity or a patient who doesn't have capacity. So that information will already be given to you. Okay, and who you're talking to in the task. The words in which we use when we do a DNA CPR discussion doesn't change when you're talking from a patient to a relative. The information that we give is still going to be the same to both. Okay. So let me give you an example of how this station can come up. An elderly female is admitted to hospital with sepsis. And the source of sepsis is pneumonia. Mrs. Jones is on oxygen, fluids, antibiotics, and yet she unfortunately continues to deteriorate. Mrs. Jones has been assessed by the medical team, and she, due to delirium, has not got the decision to make, has not got the capacity to make decisions regarding her medical care. She doesn't have an advance directive, and she doesn't have a lasting power of attorney in place. Please speak to the next of kin regarding DNA CPR. This is a very common scenario, not only from an exam point of view, but as an FY1. Because you're going to see when you work in A&E, when you work in the acute medical unit, when you're on a medical ward, and you're seeing patients who are unwell, and you've given them maximum medical therapy that you can give them, but they continue to deteriorate. You have to establish what is the ceiling of care that you're willing to provide that is in their best interests. Someone without a ceiling of care, you go all the way. You resuscitate them, you do CPR, you defibrillate them, you send them to ITU, you mechanically ventilate them. But the patients in your exam, and actually in real life who you're discussing DNA CPR for, are so frail, are so fragile, elderly, multiple medical problems, that DNA CPR is the most appropriate thing for them as a ceiling of care. So how far our treatment will go, we'll give them everything we can on the ward to try and keep them, to try and reverse their acute medical illness, oxygen, fluids, antibiotics, etc. But if that heart or that lung was to stop, that would be the end. We would not be trying to artificially resuscitate that patient. Okay? And in patients who lack capacity, only one person or group of people have the ability to make that decision. That is the medical team. Nobody else. No advance directive, no lasting power of attorney, only the medical team. Now, it is ethical to involve the next of kin in that decision-making process, the patient's closest relative. Of course, you have to explain it to them that we're going to make this decision. So let's have that discussion about what a doctor is expected to tell a patient or a relative when, well, confidentiality goes out the window. Someone just mentioned about confidentiality. Confidentiality goes out of the window when patients lose capacity. When you've judged someone lacking capacity, confidentiality is no longer an issue. So let's have that discussion, and I'll try and do this. So, hello, my name's Karam. I'm one of the doctors, and let's assume I'm talking to a relative. In fact, let me take one of you. Anyone, Mohammed, do you want to jump on? The one who asked that last question. Oh, sorry. Yes, unmute you. Oh God, because I do want to have one of these. Let's do this one.
Hi, Doc.
Hello, Mohammed. Can you hear me? Yeah.
Yep.
Perfect. So you're the son of Mrs. Jones, who's been brought into hospital with sepsis. You're aware of this. You're aware she's on treatment. Okay. And I'm the one who's come to you to talk with you about DNAR.
Yeah.
Okay. Okay. So hello, my name's Karam. I'm one of the doctors working as part of the medical team. Can I just start taking your name, please?
Yeah, sure. I'm Mohammed. I'm Lindsay Jones's son.
Ah, brilliant. Okay. And can you just confirm Mum's full date of birth as well, please, before we begin?
Yeah, she was born on 4th of July, 1948.
And just so that we're on the same page, what's your understanding of what's happened so far with Mum while she's been in hospital?
Well, I don't know. She's been quite poorly the last few days, and then we called the ambulance when she wasn't responding to us. And from what I understand from the doctors, she had some sort of infection.
Yeah, that's absolutely correct. So Mum came in quite unwell, and we found out she's got quite a severe infection. She's been managed for sepsis as a result of the chest infection that originally brought her into hospital.
Mm-hmm.
At the moment, we're treating her with maximum medical therapy. So she's on oxygen at the moment to support her breathing. She's on antibiotics to overcome the actual bacterial infection that she's suffering from. And she's on IV fluids because at the moment she's not taking much in through the mouth.
Yeah. Okay.
Okay, so that's her treatment at the moment.
Yeah.
And Mum's a little bit confused, and we've tried to have certain discussions with her, but she's not really retaining much information and not really understanding what's happening. So I've come to talk to you today about certain aspects of her care, if that's okay.
Yes, absolutely. I'm glad you're explaining this stuff to me.
Okay, thank you. One of the decisions that we have to make for every patient that comes into hospital is a decision about how far we take their care and what we can offer them in terms of the best medical treatment available.
Mm-hmm.
Now, as I've mentioned, Mum's on a lot of treatment in terms of oxygen fluids and antibiotics. Unfortunately, Mum isn't really responding as we hope she would. To the treatment that we're giving her, and she still continues to deteriorate.
Oh God. Yeah.
Sorry to have to tell you this. One of the things that I do have to discuss with you is about resuscitation. And I wanted to first ask you, is this something that Mum's ever discussed with you yourself or the wider family before? Does she have any wishes about this?
Um, she hasn't discussed it herself But when Dad was ill and Dad passed away 5 years ago, he actually didn't want this resuscitation that you mentioned, and he wanted to die peacefully. So we're vaguely familiar, but Mum hasn't actually expressed anything herself.
Okay, I understand. So CPR in general, or cardiopulmonary resuscitation, is a type of medical intervention where we artificially try and restart the heart and lungs if they stop working, essentially. So if the heart and lungs were to stop working, we would jump up and down on patients' chests to try
Yeah.
and artificially bring the heart and lungs back.
Yeah.
Let's take a normal, a younger patient, for example, without as many medical problems as Mum has. Even in younger patients with less medical issues, the chances of successful cardiopulmonary resuscitation or CPR is quite low.
Yeah.
Obviously, Mum is now older, she's more frail, she's got multiple medical issues as well. So the chances of us reviving her if her heart and lungs were to stop would be extremely low. And the experience for Mum would actually be one of that's quite traumatic, because obviously it involves, clinicians jumping up and down on Mum's chest, which could result in injuries, for example, fractures of the rib, bruising around there, which can often result in a lot of pain. And as I
Right.
mentioned, often at this age with such frailty and so many medical issues, usually it's unsuccessful.
Well, doctor, that's that's quite horrible to hear. Issue is I've lost one parent. I don't want to lose another, and that thought is really scary.
I understand, and I fully appreciate what you must be feeling at the moment. Obviously, we have to do what we feel is right for Mum in terms of how far we take her care. What DNAR doesn't mean is that we withdraw treatment. So
Okay.
we will continue to try and treat her.
Okay, good.
Continue with oxygen. We're
Yeah.
going to continue with the antibiotics and fluids and reassess her clinically, as frequently as we feel that we need to.
Yeah.
And we hope, and our aim is to make her better and try and obviously get her back home. But obviously, if she continues to deteriorate as she is at the moment, then we may have to make a decision about switching the priority of our care to, rather than treating her medically, to maintaining comfort in that case. But at the moment, we continue with our medical therapy as she's receiving at the moment.
I've got a question, doctor.
Yeah.
If her heart does stop,
Yeah.
can I, as her son, request that you try to resuscitate her at least once?
And I understand where you're coming from, and you seem like a loving son. You're saying this from a position of care for your mum, and obviously you've had a traumatic experience with Dad in the past as well. This decision that's made, because it's a serious medical intervention, is a medical decision. And we often make it with family members like yourself, so that we can discuss it together, and so that we can all be on the same page together.
Yeah.
Usually the decision is a medical one that's made.
So I can't request that you at least try once?
Unfortunately not, Mohammed, no. But what
Well,
I could do is I can ask my senior to come and
Yeah.
talk to you,
Yes, please.
the consultant who's looking after Mum, and if that helps, if you'd like to talk to a senior colleague, I'm more than happy for you to go and see if they're free to talk to you as well.
Yeah, I just need some time just to process this information, but thank you so much for explaining what's been happening, and yeah, I'm just hoping for the best here.
Absolutely. Thank you, Mohammed, for that. Thank you so much. Okay. So yeah, that's exactly the way the CPR station will unfold in the exam. Okay, talking to a relative concerned about Mum, you asked all the right questions, and I tried to explain that DNA CPR is not a withdrawal of treatment. Okay, it is simply that one medical intervention of initiating CPR is something that we unfortunately can't offer Mum, because the chances are very, very small, and often is unsuccessful. And often in this case, the risks far outweigh the benefits. Okay. DNAR. Okay, those are your two ethical and legal issues. I'm just going to add one more, which I haven't seen for a number of years, but has come up. And I think they nicked this station from Plab 2, because I believe it does come up in Plab 2 quite a lot. Let's have a look at our friend who's been drinking alcohol heavily before going to a shift. I'll paint the picture for you. You're on a medical ward round, and you're a new FY. You're new to the unit. Okay, you've got your consultant who's doing the ward round. You've got your nursing team who are accompanying you as part of the medical team, and you've got another colleague, F1, F2, and your colleague smells of alcohol. Your task is to talk to that colleague about what your concerns are. Okay, and it's not only you who's smelled the alcohol, it is also the nurse who's with you on the ward round has also smelt alcohol from your colleague as well. Please go and talk to them. It's an interesting scenario. I don't really think this is going to come up in your exam, but I have seen it before. So I will cover the intricacies of managing this case. Okay? This used to be a common SJT question, which fortunately is now out of your application system for UKFPO. Thankfully for most, I would say. This person or your colleague of yours who's been drinking alcohol, who smells of alcohol, the first thing that you need to do, if you have a concern, if you have a concern regarding a colleague's behavior or etiquette or smell or dress code or whatever it may be, is to first of all talk to the colleague and figure out, is there a reason behind this? Now, your task is not to take an alcohol history from him. You're not his doctor. You're not his GP. You're not his consultant. You're not his clinical or educational supervisor. You're a concerned colleague. Okay? You're a concerned colleague. You're concerned from two perspectives. Number one, for him or her, and number two, for your patients. Okay? You know, you've got someone who is potentially under the influence of alcohol or maybe drugs, okay, who has come in and who's on a ward round, who's, you know, a part of the team doing jobs for patients. You know, there's a risk that this colleague is not fully there because they're under the influence. So your task is to talk to them. So you bring them to the side, and obviously you walk in the station and your colleague is sitting there. And this is a little bit different to the other ones because you don't walk in and start introducing yourself. Can I clarify your name and your date of birth? It's a little bit more informal because it's a colleague. Okay, so you can address them a little bit more informally. Introduce yourself. Say you're one of the new FY1s on the ward. You know, you've not really had a chance to meet one another yet, and that you've come to talk to them about something that you've noticed whilst on the ward round. I wouldn't go into too much rapport building and start asking about their life history or what they like to do as hobbies. Forget about all that. Start with the niceties in terms of informal introductions, how they're getting on in the ward, how they're coping, and move on to what your concerns are. And your concern is that there is a smell of alcohol coming from them. And unfortunately, you're not the only one that's noticed this. One of your colleagues has noticed this as well. And what this doctor is going to do is he or she is going to try and refuse initially, saying, oh, no, I haven't been drinking, no. And, you know, why are you saying these things to me? And say, you're not accusing them of drinking, but what you can perceive is that smell of alcohol is coming from them. Okay? And they'll tell you that they've been drinking at night heavily recently because of some personal tragedy that has taken place within their home environment. You don't need to go into that much detail. They may give it to you. If they don't give it to you, you don't need to probe too far. Okay? But I think the task was his girlfriend left him, she ran away, and he turned to the bottle. And in an attempt to down his sorrows, he used alcohol as that escape mechanism. And unfortunately, today, he has been caught smelling of alcohol. So he didn't drink at work. If someone drank at work, necking alcohol back at work, that's a different issue altogether. You know, if you walk into the doctor's mess and you see your registrar, you know, doing, you know, tequila shots, that's a little bit different. That's straight to the GMC. That's a GMC issue directly. But this is a little bit different because he's been drinking outside of hospital grounds. And you could say that whatever happens at home is his or her responsibility. It's his or her right, which in a way is true. But someone who's spending large amounts of time at home drinking late at night, coming to work late in the morning and smelling of alcohol, that could put an issue in terms of clinical judgment and overall clinical performance. And you have to make that, you have to make your colleague aware that although you're really sorry that they're struggling, in their personal life at the moment. Okay. And if there's anything that you can do, if they want to talk to you about it, by all means, you can listen to them. There's no harm in that. Okay. But obviously, because you've smelled alcohol and a colleague has, there's always that chance that the patients may have smelled alcohol on you as well. And that puts a dampener or damage to that trusting relationship that doctors and patients build with one another. A doctor is held, even nowadays, in quite high esteem by patients. And you have to try and maintain that patient-doctor integrity and relationship as best you can. Smelling of alcohol, looking unkempt, coming late to work is not that professional attitude that you should be presenting when you, particularly at any stage of your career, but particularly when you're just starting your career, okay, as an FY1. So when you talk to them, try and get a little bit of a sense as to why this may be the case, and your colleague will talk quite freely and openly to you, okay, about the reason. And they're struggling mentally and emotionally with the loss of their, the separation from the girlfriend or boyfriend, and that they've unfortunately turned to alcohol. You, rather than being patronizing and trying to reel off GMC guidance to them, that's not your task. Yeah, your aim is to try and make them understand a little bit about what could happen as a result of, first of all, drinking alcohol before shifts at night. You're going to come into work tired. That alcohol may still be in your system. Your judgment may be impaired. Your overall clinical performance may be, not as good as it was if you weren't under that same influence of alcohol. And then a reminder that if, we see something as colleagues, patients may see this as well. Patients may smell this as well. And that could put a real barrier in terms of, or a real breakdown in terms of that doctor-patient trust relationship that we've tried so hard to build in the first place. And then I guess it falls onto management then. Again, this is not an alcohol history. It's not telling him go to Alcoholics Anonymous or go and take a camprosate. No. This is about offering him the advice about whom that person should seek help from going forward. Now, as FY1s, as foundation year doctors, during your foundation year 1, you will have one nominated supervisor that looks after you for the entirety of the year. Okay, one supervisor. That supervisor is your educational supervisor. They are the ones that are not in charge, I should say, overseeing your portfolio, ensuring that you're reaching your educational targets for you to essentially move from a provisionally registered foundation 1 doctor up until foundation year 2, making sure that you've done all your exams, your PSA, your portfolio requirements, etc. The educational supervisor also has the responsibility of your mental, physical, and emotional well-being through your training program as well. So offering you that pastoral care that you require to try and get you through the foundation year 1. Okay. So really, someone who's struggling at work as a result of personal issues, that should really be escalated to the educational supervisor first and foremost. They should ideally go and talk to them. Okay, and you tell that to your colleague that, please, what I would recommend now is you go and talk to your supervisor, your educational supervisor, regarding getting help for this. Okay, and also the GP. So in terms of treatment, you know, maybe he has got an alcohol issue now. The treatment will come from his GP, but his overall sort of care should come from the educational supervisor. Then it's the educational supervisor's role to tell him, go to the GP, not yours. Now you have another supervisor. The other supervisor is a clinical supervisor, and you'll have 3 in the year. If all goes well and you pass your 3 rotations, you'll have 3 clinical supervisors, 1 for each rotation. The clinical supervisor is to ensure that your clinical activities that are undertaken in their department are at your level, okay, at your level of competence as well, that your workload is shared equally amongst the staff that are working on that ward, and to make sure that your day-to-day ward activities are monitored and your progress clinically is monitored through your 4 months. So you have to be signed off from your clinical supervisor and your educational supervisor every 4 months. So this alcohol drinking colleague of yours has to meet both, okay? Both the clinical supervisor and the educational supervisor. And I guess the final thing is that they should go home. You can't have a colleague who's sitting at work, stinking of alcohol, continuing to do a ward round. It's just not, it's not ethical, okay? They should be at home. Okay? So you tell them, go and speak to your supervisors, okay? And if they can't get in touch with their supervisors, then the consultant in charge of the ward should be the, you know, the sort of next, they have to inform the consultant as well. Or if they're not available, at least the registrar that they're going home. And you know, they don't necessarily have to tell the consultant or registrar on the ward the reason as to why they're going home, but they certainly will have to discuss it with their supervisors. Okay. And then I guess the final thing will be to ensure that someone is aware that those patients are reviewed, and ensure that any management plans that have been started and any jobs that have been done by your colleague are reviewed to make sure that no mistakes have been made as well. Okay, so that's a brief overview of how to manage an alcohol colleague. Please don't take an alcohol history, and please don't offer them treatment for alcohol either. That's not the case. That's not your task. Okay, it's more of an ethical. Final thing about hierarchy, in terms of escalation of concern, as an F1. As an F1, if you have concerns regarding patient care, or you know, things that are happening to you, bullying or whatever, yeah, the first thing is you can either ask the consultant on who's looking after the ward. Now, the consultant can be your clinical supervisor, but doesn't necessarily have to be them, because they can have multiple consultants that are working in a particular department. Okay? Usually you can go to your consultant, but it will be either the clinical and or educational supervisor. If there's an issue regarding, for example, something that you have done, for example, this alcohol drinking colleague, and your educational supervisor or clinical supervisor feel that this matter is beyond them, and they feel that they need more senior input, then they will approach your foundation program director. Okay, so you'll have a foundation program director that looks after your, you know, all of the FY1s in a particular deanery. Okay. Beyond that, if an issue remains unresolved, then unfortunately it will be taken a step higher, which will be the General Medical Council.